Good morning. I think we're live here, so I'm going to go ahead and get started. I just want to welcome Dr. Blitshteyn, who is going to be giving us grand rounds this morning. She is a neurologist specializing in autonomic disorders and is the director and founder of the Dysautonomia Clinic, where she provides consultations for patients with various autonomic syndromes. She also serves as clinical assistant professor of neurology at the University of Buffalo Jacobs School of Medicine and Biomedical Sciences. So it's my great pleasure to welcome Dr. Blitshteyn this morning and welcome everybody to Grand Rounds. Really one quick housekeeping piece. At the end of this presentation, we are going to have a brief award for a teaching award, and Dr. Doherty will be giving that at the end of Dr. Blitshteyn's presentation. Thank you.
Okay, can you see my slides? Oh, what? It skipped.
Yes.
Okay, and can you hear me well?
Yes.
Okay, very good. So thank you very much for inviting me today. I'm a neurologist specializing in autonomic disorders, and I'm the director and founder of this Autonomic Clinic in Buffalo, New York, where I see patients with all types of autonomic disorders, including now these long COVID patients. I will be talking today about autonomic disorders in clinical practice. We will review the autonomic nervous system, common and rare autonomic disorders, diagnostic tests that exist to evaluate patients, as well as various treatment options that we have available today. I'm going to start with a case of my patient, who is a 38-year-old nurse practitioner with a 5-year history of fatigue, dizziness, palpitations, and recurrent syncope. She's now unable to work. Her past medical history is remarkable for asthma, allergies, concussions when she was younger, all without loss of consciousness, kidney stones, and hernia repair. She's had these illnesses that were labeled as recurrent viral illness. She also had confirmed recurrent C. diff colitis. Her course was progressive of the illness, and she's had fatigue, generalized weakness, orthostatic intolerance over the years. That's in spite of me treating her with various medications for orthostatic intolerance. Her physical exam was remarkable for postural tachycardia and a stand test with orthostatic symptoms. And motor, sensory, and cerebellar exam was unremarkable. EMG, MRI, this was all normal. A skin biopsy obtained from the leg showed borderline reduced epidermal nerve fiber density at the distal leg. Her tilt table test was positive for POTS. All other cardiac tests were unremarkable. And her blood tests were remarkable for elevated ANA, 5 times normal, elevated sedimentation rate, and elevated C-reactive protein. All other autoimmune markers, including Sjogren's antibodies, were negative. So what's the diagnosis? Well, we know she has POTS on a tilt table test and a stand test. Does she have small fiber neuropathy? She has no neuropathic pain or any pain of any kind. Is this chronic fatigue syndrome, whatever that label implies? Could this be a generalized anxiety disorder, major depression? One neurologist felt that maybe she has functional neurologic disorder, FND, and the cardiologist thought that her symptoms could be due to deconditioning. And then we are left with this question: is this some kind of autoimmune disorder? But she has no joint pain, no swelling, and no rashes. So we performed another diagnostic test, and my question to you is, which one? Which one do you think we did next? You can put things in the chat box, or you can yell out. I'll give you a couple of seconds. Okay, well, since we have no answers and since we are pressed on time, I'll just go ahead and say that I did a minor salivary gland biopsy, which was sent to Johns Hopkins Sjogren's Center. And the biopsy there showed focal silodenitis with a focus score of 1. And this is diagnostic of Sjogren's syndrome. But as you recall, her Sjogren's antibodies were negative. And this is not uncommon because negative antibodies can occur in at least 60% of patients with Sjogren's, especially in those who present with neurologic complications. So her final diagnosis, POTS with autoimmune markers, also known as autoimmune dysautonomia, secondary to Sjogren's syndrome. Let's define terminology. Dysautonomia is a general term used for any autonomic disorder or impairment, sort of like we say headache without defining the type. Thick textbooks have been written on this topic, but we will concentrate on topics that are related to diagnosis and treatment of common autonomic disorders that you probably encounter in your clinics. So autonomic neuropathy refers to dysfunction of the peripheral autonomic nerves. There is also small fiber neuropathy, which is not the same as autonomic neuropathy because autonomic neuropathy is a subtype of small fiber neuropathy. Common autonomic disorders are postural orthostatic tachycardia syndrome, neurocardiogenic syncope, neurogenic orthostatic hypotension. These are common. And then we have less common autonomic disorders, which is your multiple system atrophy, pure autonomic failure, and autoimmune autonomic ganglionopathy, or AAG. There are rare autonomic disorders as well, familial dysautonomia, autosomal recessive this disease that's prevalent in Ashkenazi Jews is one of them, and amyloidosis is another. What is autonomic nervous system? It's an output efferent system that controls visceral function. And as you all know, it consists of sympathetic, parasympathetic, and enteric nervous system. This output system is triggered by two main inputs. One is sensory input from visceral receptors, somatic receptors. The second one is from the brain, and those areas that are involved in homeostasis, emotions, and stress responses. Functions of the autonomic nervous system, I think we all know them, but let's review quickly. The sympathetic system is critical for maintenance of arterial blood pressure. It regulates blood flow, thermoregulation, and response to stress, metabolic, emotional, or exercise. And this is not surprising that our patients have problems regulating stress, whether it's metabolic, emotional, or exercise, as exercise intolerance is quite prevalent in our patient population. The parasympathetic output, we need this for beat-to-beat control of heart rate, motility of esophagus and stomach, also urination and erectile function, but it's also a secretory system that controls salivation and lacrimation. Again, not surprisingly, a lot of our patients have gastric motility disorders or esophageal motility disorders because the parasympathetic system is not functioning properly. The enteric nervous system is also there, and it controls motility and secretion of the gut and defecation. Again, problems with GI motility disorders are common in our patients. Let's remind ourselves the basic pathways of the autonomic nervous system. As you recall, the sympathetic system is located in the thoracolumbar region, with the first neuron being short and synapsing at the paravertebral sympathetic ganglia. Then there is a long second neuron that ends in end organs. Note that acetylcholine is used in preganglionic synapse and norepinephrine in postganglionic. The parasympathetic is the cranial sacral system, with the first neuron being long and synapsing at the end organs, and the second neuron being very short. Note the long vagus nerve, obviously very important, as it provides cardiovagal input to the heart and the parasympathetic input to the gut. The entire pre and post ganglionic system uses acetylcholine as the neurotransmitter. Centrally in the brain, as you see the pathways are quite complex, but let's emphasize the anterior cingulate gyrus and insular cortex that are important in behavioral arousal, painful stimuli awareness, emotions, stress response, and homeostasis. We follow this pathway down through the amygdala, hypothalamus, and the brainstem of periaqueductal gray, down to the medulla. And we have these three important nuclei of the vagus here: nucleus tractus solitarius, dorsal motor nucleus, and nucleus ambiguus. And if a patient has lateral medullary infarction that affects these nuclei or tracts, they can have dysregulation of blood pressure and all autonomic functions as part of central dysautonomia. And this leads us to what other central dysautonomias are there. Well, we have the degenerative disorders, multiple system atrophy, pure autonomic failure, dementia with Lewy bodies, and Parkinson's disease. You can have trauma to the brain or spinal cord, including concussions, which is a known trigger of various autonomic disorders, most commonly POTS. And we have hereditary, for example, fragile X tremor ataxia syndrome and mitochondrial disorders. Peripheral autonomic disorders are numerous and can be due to metabolic, toxic, hereditary, autoimmune, inflammatory, immunologic, and post-infectious causes. If you look at the metabolic, as we all know, the most common cause of peripheral neuropathy in the United States is diabetes. And similarly for the autonomic disorders, diabetes and vitamin B12 are very common. In the toxic category, we have chemotherapy, alcohol abuse is the most common in the world, and heavy metals, which is more rare, I think, in my clinic. Hereditary peripheral autonomic disorders can happen from Fabry's disease, and I have 2 patients with that. There is familial amyloidosis, mitochondrial disorders that are not, most of them are not clearly defined. And the autoimmune inflammatory category, this is your Sjogren's syndrome that our patient had, but there could also be antiphospholipid syndrome, lupus, rheumatoid arthritis, celiac. Here is the paraneoplastic syndrome, which can be associated with autonomic disorders, which we test with the paraneoplastic serum panel that usually goes to Mayo Clinic Rochester lab. Autoimmune autonomic ganglionopathy is something we're going to discuss shortly, and inflammatory bowel disease. In the immunologic category, we have common and selective immunodeficiencies that are sometimes actually more prevalent in our patients with SPOTS than in general population. Mast cell disorders are quite common. At least 20% of our patients have mast cell activation syndrome, not mastocytosis, which is the myeloproliferative disorder that's quite rare. And here is the infectious, post-infectious. And then this category is going to be mono, it's going to be flu, it's going to be Lyme, and now it's going to be COVID-19. How do we measure the autonomic nervous system? By performing autonomic function tests. The standard laboratory testing evaluates the cardiovagal, pseudomotor, and adrenergic functions. Standard laboratory tests includes cardiovagal function, which is testing the heart rate response to deep breathing at a defined rate and to the Valsalva maneuver. We'll talk about that in a second. Pseudomotor function is evaluated with QSART, quantitative pseudomotor action reflex test, and thermoregulatory sweat. We'll talk about that in a second. And then Valsalva, blood pressure and heart rate response to Valsalva, and the tilt table test evaluates adrenergic functions. So what is Valsalva maneuver? Well, as I just mentioned, it tests cardiovascular, parasympathetic, and sympathetic nerve fibers. And as you see in the picture here, the patient exhales into a one-way mouthpiece connected to a sphygma manometer. Valsalva maneuver is very important because it can tell us whether baroreflex is intact. This diagram here shows a healthy patient that has a healthy Valsalva maneuver. It has 4 phases, and as you see in this diagram, I'll just point out that initially blood pressure goes up with exhalation, intrathoracic pressure increases. This is phase 1. Venous return goes down, cardiac output goes down, and blood pressure, rightfully so, goes down while heart rate is compensating by going up. Here, barrier reflexes kick in, results in peripheral vasoconstriction, which stops the blood pressure drop. It stabilizes it here, and then blood pressure overshoots. That's very normal in phase 4, and the heart rate goes down. The ratio of highest heart rate to lowest heart rate is what is reported as Valsalva ratio. And here is your Valsalva maneuver again in normal patient or healthy patient in A. And then you have an abnormal Valsalva in a patient with diabetic autonomic neuropathy. Note how there is no phase 4 and how it takes longer for the blood pressure to recover, and the heart rate in green never goes up. This is because there is an impairment of the barrier reflex or partial adrenergic failure. We have a heart rate variability test to deep breathing, and it evaluates the parasympathetic system. Patient lies down on the table and takes 6 breaths per minute very slowly. And we determine heart rate variability by the difference between maximum and minimum heart rate, which is averaged. And that's an index of cardiovagal function. QSART, or quantitative autonomic, quantitative sudomotor axon reflex test, is important because it will help us differentiate where the lesion is in the sweat response. Is it in the peripheral nervous system, in which case QSART is abnormal, or is it normal? And if there is a sweat box test abnormal, then that's a sign of CNS problem or autonomic failure. So in this axon reflex test, acetylcholine is used in a capsule to stimulate the sweat gland along with the small current, and this leads the gland to produce sweat output. The area under this curve is measured and reported as sweat output volume, and sweat latency is also reported. Here we get to another test that can help us with differentiating perspiration disorder called thermoregulatory sweat test. And it's a fun test that uses a sweat chamber with infrared heat lamps that heats the body to oral temperature or 38 degrees Celsius, whichever comes first. The body is covered in alizarin S powder, which turns the color from yellow to purple when it comes in contact with sweat. And here you see different patterns in this picture. And you see global pattern where the body does not sweat, but hands and feet do. And this is compatible with central pattern of multiple system atrophy and pure autonomic failure. And then you see in the distal pattern, you see the body sweats, but the feet don't sweat. And that's compatible with small fiber neuropathy pattern. In this multifocal pattern, you see patchy areas of sweating, and this pattern can be seen in AAG and autonomic neuropathy associated with autonomic diseases like Sjogren's syndrome. Then there is also kind of a mixed pattern that can also be common in multiple sclerosis. Multiple system atrophy. So what if these great informative autonomic tests are not available to us? And they are not in many cities across the United States. They're not available in Buffalo, and I think they're not available in Seattle. So we have to make the best with what we've got, and we have many tests that we can use. We can get tilt table test, a skin biopsy to evaluate for small fiber neuropathy. We can get EMG to rule out obviously large fiber neuropathy, CADP, and myasthenia gravis. which can sometimes enter into the differential diagnosis when patients present with generalized weakness or weakness in the legs, as they often report. We have blood and urine tests that test for autoimmune disorders, vitamin deficiency. Can also test for presence of protein in the urine and blood and gammopathies. We can do a Holter monitor, 30-day event monitor, cardiac echo, and exercise stress test to rule out cardiac arrhythmias and structural heart disease on our patients. There is a lip biopsy to rule out Sjogren's, which we must think about when a patient presents with certain features. There is a fat pad biopsy to rule out amyloidosis. We have gastric emptying tests and other GI motility tests to test for motility in our patients who present with significant GI complaints. Similarly, there are urodynamic studies to assess whether there is evidence of neurogenic bladder or overactive bladder. And sleep studies also very important. I also obtained MRI of the brain, obviously, to see, if there are any evidence of structural or demyelinating lesions or any atrophy if I'm thinking about MSA. How do we diagnose autonomic disorders? In the same way we diagnosed many neurologic conditions, we have to rely on detailed history and exam findings. One needs to be on the lookout for the history of orthostatic intolerance and other autonomic symptoms like temperature dysregulation, neuropathic pain, exercise intolerance, and fatigue. On physical exam, you look for signs of dryness, since dehydration is a common feature of dysautonomia patients. And you also look for acrocyanosis. Look at this photo, and this is what it shows. It shows a photo of a normal skin on a healthy person. And then you see this discoloration in the lower extremities when they stand up. So make sure you stand them up, because if they're sitting down with their feet up, you're not going to see this difference, because there is no blood pooling or skin mottling in the supine position. You should perform an in-office stand test, which in some studies have been shown to be as good enough substitute when a tilt table test is not available. And now, in the time of pandemic and telemedicine, a 10-minute self-administered stand test performed by the patient can be a fair assessment of the orthostatic vital signs. In the neurologic exam, you look for, is there evidence of dilated pupils, atonic pupils, areflexia? Sensory exam findings, do they have comorbid small fiber neuropathy? Are there any signs of Parkinsonism, which would obviously make you think about central dysautonomia like MSA and PAF? Is there ataxia and unsteady gait? So all of these are quite important. So we have skin biopsy, which is an easy test that we can do at the clinic, which takes about 10 to 15 minutes for me to complete. And companies like TheraPath and others provide free testing kits, which utilize a punch biopsy device to remove a sample, usually from behind the ankle and at the thigh. The samples are then sent to the pathology for epidermal nerve fiber density and sweat blood density assessment. And it uses immunohistochemistry. And as you see from this interesting photo, here is A, which is a normal sample, and you see these little fibers, small nerve fibers, they are present. Here in B, you see none of those, and that's a sample from a patient with small fiber neuropathy. And now you can also request a stain for amyloidosis to rule that out. So what is small fiber neuropathy? As you recall from neuroanatomy, small, thinly myelinated alpha A delta fibers and unmyelinated C fibers. They enter spinal cord at the lateral zone and crest over in the anterior commissure to the opposite side, and then ascend to the thalamus in the anterior lateral system. These fibers carry pain and temperature sensation from the body. And that's what we test for when we want to see if patients have small fiber neuropathy. Small fiber neuropathy cannot be diagnosed by EMG, which tests large fibers, and sensory conduction studies in patients with small fiber neuropathy are typically normal. So it's very important that after you get the normal EMG, that you think about getting either QSART if it's available, or skin biopsy. Both, either or both can be used to see if there is evidence of small fiber neuropathy with reduction of epidermal nerve fiber density or sweat gland density. As I mentioned before, people use these interchangeably, small fiber neuropathy and autonomic neuropathy. It's not correct, because autonomic neuropathy is a subset of small fiber neuropathy. Symptoms of small fiber neuropathy can be this neuropathic pain features that we all know, also including itching and coldness, and not necessarily pain or burning. And sometimes, actually in my patients, very often there are no neuropathic pain features, and yet the findings still show small fiber neuropathy. So I think that's very important, because I think we're not trained to think that way, that they can still have small fiber neuropathy without neuropathic pain reported. Signs is your loss of temperature and pain sensation distally in the case of diabetes and vitamin deficiency, or it can be non-link dependent and patchy, like in Sjogren's, Lyme, and other autoimmune disorders. This is really interesting, that 50% of patients who are labeled with this diagnostic label that I'm not a fan of, fibromyalgia, they have small fiber neuropathy. And also 50% of our patients with spots have evidence of small fiber neuropathy. There are numerous causes of small fiber neuropathy, as you see from this table, and diabetes or glucose intolerance is the most common cause of small fiber neuropathy, with Sjogren's being the second most common cause in the United States. That's very important and needs to be emphasized, since many physicians think they ruled out Sjogren's as soon as they see negative anti-SSA and anti-SSB antibodies. So when there is a high clinical suspicion and positive markers of autoimmunity, as in the case of the patient that I presented, do get a lip biopsy to diagnose Sjogren's, because lip biopsy or minor salivary gland biopsy is the gold standard. When you go down this list, you see really many autoimmune disorders can cause small fiber neuropathy. There are also nutritional deficiencies, all kinds of vitamin deficiencies, celiac disease, Lyme disease, and then of course hereditary disorders. And this table was created before the pandemic, so we have to add COVID-19 because it too can cause dysautonomia and small fiber neuropathy. So small fiber neuropathy treatment options are there, maybe not very effective, but we all know them. It's the symptomatic management with neuropathic pain medications, your gabapentin and Lyrica and Cymbalta and tricyclics. We have topical medications, which are lidocaine and compounded pharmacy gels and creams with ketamine and other pain medications. And then there is neuromodulation with TENS unit and non-invasive vagus nerve stimulator that is now appearing to be, also utilized. But when we find this underlying cause, of course, it can be so much better in terms of treatment control. If there is evidence of hyperglycemia or pre-diabetes, not even diabetes yet, but then, we do that through dietary and lifestyle and maybe medications for pre-diabetes. When there is a vitamin deficiency, we correct that. Sometimes patients respond to diet, including gluten-free diet. And then last but not least, immunotherapy. Immunotherapy we think about when all else fails, so to speak, but also when there are clear evidence of autoimmune markers. And we'll talk about in a second more thoroughly. Briefly, AAG, autoimmune autonomic ganglionopathy, is a rare type of autonomic neuropathy. In AAG, ganglionic acetylcholine receptors block this ganglionic transmission for both sympathetic and parasympathetic system, resulting in significant autonomic failure. I also like this diagram because it nicely shows various adrenergic and muscarinic antibodies that appear to be very important in the pathogenesis and may actually be the biomarkers for POTS and other common autonomic disorders. So for example, we have several good studies that show elevated alpha-1 adrenergic receptor, beta-1 adrenergic receptor, and M3 and 4 receptor cholinergic antibodies in patients with SPOT, small fiber neuropathy, and CRPS. AAG typically presents in midlife with an average age of 50 and can follow a viral prodrome. At least 70% of patients present with orthostatic hypotension and GI hypomotility, and 25% of patients have neuropathic symptoms. Motor exam is usually normal, which differentiates it from Guillain-Barré syndrome. If a patient is stabbed, elevated protein may be found, but at the core of AAG is elevated ganglionic acetylcholine receptor antibody at high titers. However, acetylcholine receptor antibody negative AAG also exists, which suggests that other yet unidentified antibodies to the autonomic ganglia may be at play here. So a tilt table test is widely available and is essential to diagnosing autonomic disorders. Here you see that the patient lies down and the blood pressure and heart rate and beat to beat heart rate is measured as a baseline supine. Then the patient is tilted 70 degrees for 10 minutes. Sometimes cardiologists use 40 minutes or until syncope occurs, but in neurology, we're not so mean. And then the patient is returned to supine position and their vital signs are monitored. Symptoms are very important. So we document those when the patient is standing because it's not just about the vital signs. So let's look at some of the common patterns on the tilt table test because I think these are quite fun to look at. The first pattern is that of neurogenic orthostatic hypotension. So we have blood pressure in blue and heart rate in pink. As you see here, when the patient is tilted up, blood pressure begins to decline. And the heart rate is not changing much. So that means that there is clear cerebral hypoperfusion happening. That's an abnormal pattern, but when the patient is returned to supine position, heart rate and blood pressure normalize. That's neurogenic orthostatic hypotension. The second common pattern is vasodepressor or neurocardiogenic syncope. Here you see patient is tilted, blood pressure and heart rate are holding strong and steady. And then all of a sudden, maybe minute 8, 9, could also be longer, maybe even at 15 minutes, there is an abrupt drop in heart rate and blood pressure, both. Obviously, there is absence of cerebral perfusion at that time, and there is fainting going on. The patient is returned to supine position, and heart rate and blood pressure become normal. And this is also a very common pattern, POTS. Again, the patient is tilted. You see that blood pressure is holding steady, that's normal, but heart rate continues to rise excessively. At that time of excessive heart rate, the patient experiences pre-syncopal symptoms, weakness, nausea, headache, dimming of vision. And when they are returned to supine position, heart rate and blood pressure normalize. So we get to common autonomic disorders and their diagnostic criteria. POTS is defined as an increase in heart rate of at least 30 beats per minute or greater than 120 within 10 minutes of a tilt or a stand test. That's good that this criteria is there because if there is no access to tilt table tests, you can do a simple stand test at your clinic. A second criteria is that blood pressure should be unchanged because if blood pressure drops and heart rate increases, that's actually a normal compensatory heart rate increase. And that's not consistent with SPOTS. That's just your body keeping perfusion to the brain. And the third criteria is that symptoms of presyncope and orthostatic intolerance are present chronically for at least 6 months. Neurocardiogenic syncope is defined as abrupt loss of consciousness due to sudden fall in blood pressure, heart rate, and cerebral perfusion. And then orthostatic hypotension is a fall of systolic blood pressure of at least 20 millimeters of mercury or a diastolic blood pressure of at least 10 within 3 minutes of tilt-table test. So let's talk about POTS briefly, because I'm pretty sure you're seeing these patients because they are quite prevalent, and also now with post-COVID, everyone is going to see these patients, especially neurologists. So there are symptoms of cerebral hypoperfusion, which is lightheadedness, weakness, either generalized or weakness of the legs specifically, difficulty concentrating or brain fog. There are symptoms of sympathetic activation, such as tachycardia, chest pain, vasomotor and autonomic symptoms, and storms. And then we have associated manifestations of autonomic instability in the form of migraine and GI motility disorders. Who gets POTS? Well, at least 1 to 3 million of Americans and many more worldwide had POTS before COVID-19. Obviously, that number is a lot higher now. 80% are women of childbearing age, but we have obviously younger women and older women as well. 93% are Caucasians. Reasons for this racial disparity is unknown. Could it be genetic predisposition? Could it be a variability in sodium absorption in the renin-angiotensin-aldosterone system, which is one of the pathophysiology of POTS, actually? And in one of our papers, we said that Black patients are particularly vulnerable to misdiagnosis or a lack of diagnosis, because healthcare practitioners view this POTS as a disorder of Caucasian, young women. POTS rarely exists alone and involves a number of important comorbidities. Small fiber neuropathy, as I said, migraine is very common. Ehlers-Danlos syndrome or joint hypermobility disorders occur in at least a third of our patients. And then we have autoimmune disorders, comorbid in 20% of patients, as well as mast cells and various immunologic dysfunction. There is a lot of question marks here because we just don't know. We haven't studied, the presence of genetic abnormalities. We're just beginning to uncover this in our research field. And then is there some kind of mitochondrial dysfunction happening in our patients? So we'll talk about autoimmunity next. Years ago, I received a grant to study autoimmune markers in autoimmune disorders in patients with POTS. I noticed that a significant number of my patients had positive markers of autoimmunity and comorbid autoimmune disorders. So when we applied statistical analysis, we found that POTS patients had a higher prevalence of ANA, antiphospholipid antibodies, and really all other autoimmune markers than the general population. As you see from this figure, the prevalence of most defined autoimmune conditions was higher in this cohort of 100 patients with POTS than general population. And Hashimoto's thyroiditis was the most prevalent, occurring in 11% of patients. 25% had positive ANA. And then, there were some non-statistically significant increases in our cohort as well, including Sjogren's syndrome. So more recently, there has been significant research interest in the last few years in POTS as an autoimmune disorder. And while we haven't conclusively answered this question, it appears that POTS may have strong autoimmune basis. As you can see, various antibodies have been identified in patients with POTS, and these antibodies are critical to the structure and function of the sympathetic and parasympathetic nervous system. So it makes sense that these antibodies would be potential biomarkers in this disorder. And in 2020, we had made significant progress when an animal model was introduced by Dr. David Camp from the University of Oklahoma. He immunized rabbits with adrenergic receptor peptide and simulated POTS in rabbits. Unfortunately, Dr. Camp died of COVID this past year, so that was very tragic for our field. All of these findings certainly have therapeutic implications with immunotherapy, which is already being used in certain selected patients with spots quite effectively. And we'll talk about that in a second. So POTS treatment includes non-pharmacotherapy and pharmacologic therapy. I won't go into details on treatment, but I will emphasize that we certainly use beta blockers, Florinef, Midodrine, Mestinon, Ivabradine, and other medications that we use for dysautonomia. Additionally, other therapies are emerging as effective in selected patients with dysautonomia, like IVIG and like subcutaneous immunoglobulin and plasmapheresis in certain very selected cases. There are also ongoing studies on non-invasive vagus nerve stimulator in POTS, which would be great to have in our toolbox because many patients do not tolerate pharmacotherapy well. There is Dallas exercise protocol that can benefit a certain subset of patients as well. But commonly, this is a common question that I'm often asked by my colleagues: when do you use IVIG? And unfortunately, all recommendations are based on case reports, case series, and personal experience of neurologists who manage these patients. We do not have clinical trials on these rare disorders like AAN, AAG, but we still use immunotherapy. We also don't have the outcomes of ongoing clinical trials on POTS or autoimmune small fiber neuropathy. So recently, a Dutch trial of IVIG in patients with idiopathic small fiber neuropathy of 30 patients who received IVIG showed no significant effect on pain with IVIG. That was published in Neurology Journal just a few months ago. But larger studies targeting patients with small fiber neuropathy and autoimmune markers are needed. We need those. Right now, we have an ongoing double-blinded placebo-controlled trial of IVIG in patients with SPOTS at the University of Texas Southwestern Medical Center. So we'll see how that pans out. But we do use IVIG for AAN, AAG, small fiber neuropathy with autoimmune markers that do not respond to standard therapy. Severe treatment refractory POTS with autoimmune markers, we use it for these patients. And we use it for dysautonomia associated with Sjogren's syndrome or another autoimmune or immunologic disorder. And IVIG is used for my patient that I presented here. And quickly, we'll do POTS prognosis because I don't want to run out of time for questions. You know, there is a notion that POTS has a good prognosis, but it has to be emphasized that less than 20% of pediatric POTS patients fully recover, which results in a huge financial and psychological burden for these patients. At least 25% and up to 40% in some studies are unable to work or attend school. Disabilities comparable to COPD or congestive heart failure. And POTS predominantly affects women of childbearing age, so there is a question of pregnancy there. And we found that the course of POTS is variable during pregnancy for women with pre-existing POTS. I'll briefly say that at least 60% of patients were stable during pregnancy, and 40% felt worse during pregnancy. And then 6 months to 1 year, it was about 50-50. So it's not the contraindication, but there might be worsening as well. I want to mention some clinical pearls at the end because we're at the end of the presentation. It's important to recognize that dysautonomia is very complex and full of nuance, and every patient presents with a specific set of symptoms. No two patients are alike. Having said that, certain trends emerge clinically. First, do orthostatic blood pressure and heart rate in suspected cases. Get a tilt table test for patients who present with unexplained spells or loss of consciousness, chronic dizziness, chronic fatigue, headache, palpitations, episodes of weakness. Sometimes they sound like they may be presenting like periodic paralysis patients because pre-syncope and syncope can be that diverse and can be quite confusing. So get a tilt table test. Dysautonomia is not just about the vital signs. So fixing vital signs with medications doesn't necessarily resolve the most disabling symptoms, which are fatigue, dizziness, and cognitive dysfunction. And we treat comorbid conditions as well. So I'd like to mention some mythbusters because they exist in the medical community. Number one is dysautonomia is not caused by anxiety, but anxiety can certainly be a symptom. Dysautonomia in POTS are not caused by deconditioning, but deconditioning secondary to exercise intolerance is common in our patients. And dysautonomia is not functional neurologic disorder. Oftentimes I see people use SSRIs often, if the patient appears to be anxious or depressed, but that's not the right choice. So use beta blockers, fluorinephrine, mestinon. Start on a low dose and slowly increase to a maximum therapeutic effect. Oral fluids is the main non-pharmacotherapy. We always recommend them, but sometimes when patients are very sick and deteriorating and end up in the ER, we recommend IV saline. It can be more effective than oral solutions. We use them as needed, not daily, because we don't want to use a line placement or have a risk of infection or sepsis from the line. So, as a sign of the time, I want to add one slide on post-COVID dysautonomia, although of course this topic can be a lecture in and of itself. In a recently published case series, we described 20 previously healthy patients who developed dysautonomia after COVID-19. And this was part of the long COVID or post-acute COVID syndrome PACS, if we use the CDC nomenclature. If you look at table 2, you see that 70% were women. Age range here was 25 to 65 years old. None were hospitalized for acute COVID. Most common autonomic disorder was POTS, followed by neurocardiogenic syncope and orthostatic hypotension. In this case series, 6 to 8 months after acute COVID, only 15% recovered, while 85% appear to have residual symptoms, and 60% were unable to return to work. Note that in the sample, we had 30% was abnormal cardiopulmonary testing, 20%, at least that, because not everyone was tested in March during the lockdown. 20% had elevated markers of autoimmunity inflammation, 20% had concussion, and 30% had a history of some minor symptoms, but they were never disabling, and the patients here were all fully functional. So these are some of the references that I used, and thank you for having me over. These are my research assistants and students that I've had over the years that helped me with the research studies we've done, and I'll take your questions now.
So Dr. Kamani has a question. Green light goes. Hold it. You got to hold it. Oh, hi.
Hello.
Thank you for that excellent talk. Really stimulating. I have so many questions, but we don't have time for all of my questions. I'll ask at least two. And that first case that you showed was the lip biopsy, salivary gland biopsy done because it was part of the dysautonomia workup, or was there anything in that history and physical that tipped you off that she could have Sjogren's syndrome?
Yes, that's I think is the most important question, because this patient is now obviously talked about by neurologists, rheumatologists. They discuss this case with residents and fellows. So we got to remember that Sjogren's syndrome in this patient population is not uncommon. We have to think about it, because if we don't, we're going to see these negative Sjogren's antibodies and we're going to say she doesn't have Sjogren's. So what ticks you off is the high ANA, high SED rate, and high CRP in a patient who is essentially deteriorating despite all the SPOTS management, despite midodrine and mestinon and salt. Her symptoms are very severe. She is basically bedbound. So you think, why is that? Why is she not getting better? These elevated markers of autoimmunity point there. And there was also these mild findings on a skin biopsy, right? Reduced epidermal nerve fiber density. So I'll tell you how I do it, is when I see these sick, very sick patients with elevated markers and there is small fiber neuropathy, I get a lip biopsy. And there was a Cleveland Clinic study done on the sample, and they also recommend that. So we have to think about it, and then it will enter our differential diagnosis.
Thank you. Can I ask one more quick question, please?
Sure.
If the tilt table test is completely normal, can you effectively exclude dysautonomia?
No, because as any test, there is a false positive and a false negative. And sometimes there are going to be false negative tests, especially if the patient goes in the afternoon well hydrated, they ate, there was enough fluids and salt. So I recommend they go in the morning fasting, not hydrated, hold their medications. Even with that, sometimes there is a good day. So you have to put the tilt table test in the context of clinical picture. And then if you do your 10-minute stand test and there is a trend of postural tachycardia, or nowadays the patients are so smart, they'll bring you a printout of their own heart rate and blood pressure. And you'll see that supine, they're running 60. And as soon as they stand up, always it's greater than 100. Then you still need to diagnose this with spots despite the negative tilt table test.
Thank you so much.
Anyone else? Is there anything in the chat box? I'll read. POTS is a cytokine syndrome. Inject TNF IL-6 into the nucleus tract solitarius, dysregulating ANS function, and you get a POTS-like presentation. Thus, the association with COVID and autoimmune. Perhaps we have one study of POTS patients not related to COVID that found elevated cytokines. And that, is there a problem with T cells, not just the antibodies? Yeah, perhaps it's that, but it certainly is going to be rooted in some kind of autoimmune inflammatory etiology. And that's what I put in my paper on post-COVID POTS. And then there is a question from Kristen. When do you choose to check for acquired amyloidosis? Yeah, since testing is now free, I'm assuming if there are no free light chains detected on SPEP, then you do not pursue fat PET biopsy. Right, that's a very good question. Those are rare, thankfully. You look at the history, is there a family history of another family member who died young? Also, is there a rapidly progressive course of autonomic failure, not POTS? Remember that POTS is actually associated with mild autonomic impairment. These patients with amyloidosis, they have autonomic failure with orthostatic hypotension and barrier reflex failure on autonomic tests. So if they're young and they're progressing, and especially if there is a relative who died of unknown cause, or if they have heart failure, because amyloidosis does go to the heart, or another organ failure, if there is something outside of the regular, usual presentation, then yes, we get a fat PET biopsy. You can also stain the skin biopsy with amyloid skin, but I believe a fat PET biopsy is still the gold standard in some diagnostic criteria. Any other questions? We have time. I made sure we get time for that.
Hi, one more question. Sorry to bug you. Is
Sure.
there a role for genetic studies or genetic markers in the group of patients you see, at least as part of the workup?
Well, that's where we need to go with research, but I'll tell you where it's relevant. So about a third of patients with dysautonomia POTS presentation, have hereditary connective tissue disorders like Ehlers-Danlos syndrome. And the most common, and it's joint hypermobility syndrome. The most common type of EDS, I had those slides, but I had to remove them because I was going over the time limit. So the most common form of EDS is hypermobile. Hypermobile EDS does not have any genetic markers, but we have other types. We have classical Ehlers-Danlos syndrome, and we have vascular Ehlers-Danlos syndrome. This vascular Ehlers-Danlos syndrome can be quite risky because it's associated with aortic aneurysm and organ rupture. And there is genetic test for vascular EDS and classical EDS. So when I have the patient and I diagnose them with EDS based on the Beighton score of hypermobility and all other features that I had to remove from this presentation, because it could be another presentation as well. If I have those patients and I suspect based on the skin lesions that they may have classical EDS, or if there is some kind of family history of aortic rupture or carotid dissection in their relatives or early death from aortic rupture, I get genetic tests then to rule out vascular EDS. It makes me feel better, and it makes the patient and the family feel better to know that they don't have this kind of a type with higher risk of death, and everything else then we deal with management on chronic basis.
Thank you so much.
Sure.
Thank you so much for the great presentation.
I am gonna there is one more question. I think we have time, and that's from Kristen. Can you 1 second, disappeared. Can you please re-emphasize which non-specific labs you use to help characterize generalized autoimmunity in these patients? For example, in addition to ANA, SED-rate, CRP, do you routinely check for thyroid antibodies, antiphospholipid antibodies? When do you decide to pursue Mayo Clinic autoimmune dysautonomia panel in acute or subacute onset debilitating cases? Right, so I have my own kind of template of workup, and on there is also there is always autoimmune panel with ANA, SED-rate, thyroid antibodies, antiphospholipid antibodies, Sjogren's antibodies, celiac antibodies. I always get that. I don't always get Mayo Clinic autoimmune dysautonomia panel because this panel tests for very rare antibodies that I don't think were designed to be applied to POTS patients. So if I suspect something out of the ordinary, I do get this panel, but not routinely, because this panel is also very expensive and insurance needs to authorize. And in most of the cases, this panel specifically is going to be negative. This panel originally was called paraneoplastic panel that was designed to check for paraneoplastic syndrome. And then they renamed it autoimmune dysautonomia. So I get it in a very small percentage of cases. And which treatment do you find most helpful for small fiber neuropathy? Well, I think a lot of these treatments are the same that we use for peripheral neuropathy of large fibers or neuropathic pain. I use a lot of antihistamines because our patients tend to have a mast cell dysfunction, and many have mast cell activation syndrome. So antihistamines, anticholinergics, hydroxyzine looks good because it can also be sedating at night. I use Periactin. I use actually Zyrtec and Singulair and Benadryl as well. Cromolyn sodium can help with a lot of GI symptoms and neuropathic pain. So I do use a lot of antihistamines. And then when all else fails and the patient is very troubled, disabled, unable to work, we think about IVIG or subcutaneous immunoglobulin.
I want to thank you so much for the wonderful presentation. We have a brief presentation that Dr. Doherty is going to give for a teaching award, but thank you so much. That was a fantastic presentation, and we really appreciate it.
Thank you for having me over. It's been an honor.
Thank you.
Take care.
We'll turn things over to Dr. Doherty for this year's Teaching Award.
Thank you. What a great talk. We've been doing the neurology clerkship for University of Washington med students for over 2 years now, and I've been surveying them at the conclusion of their rotation with us on faculty they enjoyed working with the most. And pretty much every one of our faculty who participated, which is about 2/3 of our neurology team, got votes. There were just 2 people who got more votes than the rest of them. And I decided to do an inpatient and an outpatient teaching award. And if the 2 recipients would like to come forward, we have Corey Hecker from Neuro ICU and Praveen Kamani. So come on up. The irony of it is the talk was about POTS, but I have POTS as gifts for you.
Thank you so much. Thank you. There you go. Thank you both for your care. Appreciate it. Thank you.
Guys, it's just wonderful that the students consistently come back and are appreciative of not being viewed as a burden and learning from all of our staff and faculty. And it's above and beyond our ask of what you do for us here at Swedish, but I think it's a wonderful thing for us to do and to work on. And I appreciate your work, and I'm sure the rest of the students that will come through will also be thrilled to work with you. Thank you.